forum. The Healthcare Forum is a community service that is sponsored by the ADS, as I said. It's not medical advice. It does not establish any doctor-patient relationship. There is no consultation. Even if you ask your personal problems during the question answer session, it is just an educational exercise and not necessarily a medical consultation, because the speaker generally does not have knowledge of your entire medical record, nor do we are legally engaged. We look at the common topics, common problems, and we also look at what is most important for us and for our listeners. The subject are very prevalent, things that happen in the community, and we like to bring the speakers who are known in their field and their authority. They are prepared well, and then they share their knowledge. So with that, I'm privileged and honored to introduce today Dr. Sujeeth Reddy Punnam. He is an interventional cardiologist who works with the Sutter Gould Medical Foundation in the Stockton area and is affiliated with multiple hospitals. He went to medical school in Kakatiya Medical College in Warangal, India, and then did his residency on the East Coast in Brookdale Hospital in New York and Chester Medical Center in Upland, Pennsylvania, and did his fellowship from Michigan State University. He is not only a wonderful cardiologist, invasive cardiologist, but also serves the community, both at political level and the community service level. He is regional director for the Pacific Zone for API, and he's very active member of the API. He runs for the offices and is well known in the API circles. He also has appeared in the My Dream TV USA regarding the COVID-19. So today he is going to talk about what is most interesting to us, that as Indians, we follow the literature. Most of us follow the literature, which is built up on the Caucasian cohorts, and research is done either in Europe or in United States, other countries, but does not represent Indian ethnicities. So people have been very interested, and back in 2006, a group got together and started this project, which is known as the Masala Project, connotes to the Indian origin, but it is acronym for Mediators of Atherosclerosis in South Asian Living in America. And atherosclerosis, as you know, it is the disease of the vascular system where the cholesterol and evil humors and other substances deposit in our blood vessels and narrow them and lead to clot formation, and then the brain hemorrhage or brain stroke, or the heart problems like myocardial infarction and other heart diseases. Actually, it's a whole host of medical conditions are there. This study continued to expand and ended, I believe, in 2018 with over 1,100 subjects, and is considered one of the major trials in our epidemiology and our cardiac health. So today we will have a flavor of that, and without taking any much time, I will invite Dr. Punnam to kindly take over, share the screen, and start his presentation. Thank you very much, Sujeeth, for joining us today.
Thank you, Deepakji. Thank you for the opportunity. I will share the screen here. So the way this started, I believe, is, as on behalf of API, for the first time, what we did is we did the community outreach program, recently around Christmas time, I think. It was heart disease in Desi, in Desi's. So I think Deepakji came to know about that ZTV program that we did, and spoke to me and said, why don't you talk to the community here? I said, sure. It's just an extension of what we were doing. So that's how it all started. So I put together some of these slides, and so in order for me to go through our Desi heart thing, I would like to go through the heart disease in general. Do you like the picture here? Yeah.
It's beautiful. It's amazing. And I wonder who did it. It does not look like a picture. It looks like some kind of work.
Yeah, it's a work actually. It's a handicraft. Yeah.
Handicraft, yes.
Yeah. So that's so what I will plan to do is I will give the basic information about heart disease in general, and then go to the Desi heart. That way, most of the things are common, but what is different in Desis, I will kind of try and enumerate on that. So for some reason, I'm not able to. Okay, I'll go from here. Okay, so brief about a heart structure. We all know, but let's just briefly go through. There are two top chambers. They're called atrium. Two bottom chambers called ventricles. I'm presuming there are a lot of non-doctors in the audience, so I'll take it that way. And the right-sided chambers of the heart deal with impure blood. The left-sided chambers deal with the pure blood. So as you can see, the impure blood from the body comes into the right atrium, goes through the right tricuspid valve that you can see here, which is a trileaflet, goes through the right ventricle. That pumps the blood into this blue structure, the pulmonary artery. That impure blood is going into the lungs. There it gets purified and then comes into the left atrium through 4 pulmonary veins. And then the valve in between the right ventricle and the pulmonary artery is the pulmonary valve in the left top one. And then once it comes to the atrium, the valve that opens up is a mitral valve. This is a 2-leaflet valve. Comes into the left ventricle. That's the main organ of the body, or the heart, sorry. So when we say heart, we are specifically dealing with the left ventricle. That's the main structure, the pump that we talk about. When it pumps out, it goes through the trileaflet valve again, the aortic valve, and goes into the red structure here called aorta. And then it branches out into various parts of the body. So as you all know, cardiovascular disease is the #1 killer. It's been like that for decades now. If you look at the whole, even in men and women, it's the same, it's the highest. The cancers come as second, and then the accidents are the third, and the lower lung disease like COPD, bronchitis is the next one, and the Alzheimer's and diabetes. So it's not only a #1 killer disease, heart disease is also #1, not only in men, it's also in women. Some people tend to have a misconception that it's only in men. It's not, it's also in women. So what are the types of the heart disease? There are various things. So on the top of the heart, there are these arteries, but like, even though the heart is in direct connection to the blood, it needs blood supply to pump. And that pump is getting blood supply through these arteries called coronary arteries on the top of it. They're called coronary arteries because when you look at it from the top, it looks like a crown. So that's why it's called a coronary artery. And then there's a valvular heart disease. Like we spoke about the 4 valves. If there is something going wrong with the valves, we call it valvular heart disease. And then if there's an issue with the pump gets weak or dilated or things like that, we call it as a heart failure. It can be a right heart failure or a left heart failure. It can be both-sided failure. And then there is rhythm. For all the heart function, the squeeze and all, you need a heart rhythm to come in. So the rhythmic activity precedes the mechanical activity. So that's why your heart rhythm is important too. And if there's anything wrong with the rhythm, you can have heart disease. So that's arrhythmia. And then there's vascular, like, cardiovascular disease, what we call. So we are actually not only cardiologists, we are cardiovascular specialists. So we also deal with the vascular disease. These arteries, subclavian, carotids, aorta, aortic aneurysm, iliac arteries that take the blood into the body, legs, and then the femoral arteries and things like that. Apart from that, cardiovascular disease includes stroke actually. Even though the specialty is in neurology deals with it, it comes under cardiovascular disease profile itself. and the stroke. It's the same thing. The heart attack is the blood supply gets diminished in the heart muscle. The same thing happens in the brain. The brain attack is called the stroke. And you might be seeing these things, the acronym FAST for recognition of the stroke. F stands for face drooping, A stands for arm weakness, S stands for speech difficulty, and time is of essence. So it's called time to call 911. So that FAST is an acronym for the stroke. So what is a heart attack and what is angina? We hear a lot about angina. Like every organ, like I just said, heart also needs blood supply to survive. This blood supply is provided by the coronary arteries. And due to some conditions called risk factors, what we call, these arteries develop fatty deposits inside the lumen called atherosclerotic plaque. So if you look at this artery, there is a muscle, and then there is a lining, endothelium, and then there is a lumen. And there are a lot of blood cells, particles going into the blood all the time. And just imagine a lead pipe in any home, right? Over the period of years, the grunge forms in it. So the same thing, any particulate material that goes through a lumen have a tendency to have some deposits. And these deposits can be fat, can be cells, and they accumulate on this endothelium and form a blockage. And the blockage is called, in scientific terms, is called atherosclerotic plaques. So when the plaque buildup happens gradually and reaches a point of about 70% or more, the mismatch between the oxygen demand and supply contributes to the heart manifesting certain symptoms to warn us so that we can take action. And that is chest pain. So in a way, chest pain actually is good. If you are having a problem and you have chest pain, that's a good thing. It's a warning. You can treat it. Some people don't have that. They're not fortunate enough to have a warning sign. Those people tend not to do good. And then the chest pain happens. This is called angina. Once in a while, the plaque ruptures abruptly, and all of a sudden, the blood clots in that area. So when like a volcano, when the plaque layer, the coating of it ruptures, the blood cells abruptly get exposed to that fat, the liquid fat that's underneath the cap, and then blood clots right away. That's the inherent tendency of the blood. That shuts off the circulation and sets in the death of the heart cell. That's called a heart attack. What are the preconditions for a heart attack? So until about 1960s, when in the 1920s and 30s, there was a significant amount of food shortage in America. After that, a lot of changes have been instituted, and as you know, a lot of genetic modification of the food has happened, and food has grown so much in size, in volume, that people started eating a lot, and they were dropping off like flies due to heart attacks. In the 60s, National Institute of Health's subsidiary, National Heart, Lung and Blood Institute, in 1948 started like a seed investment into it, and they commissioned Framingham heart study. But not until the 60s, we came to know about what happened, what came out of that study. So it's a longitudinal population-based study. So Framingham is a town in Massachusetts. It's at that point, it represented the quintessential demographic of America. Like if you look at what percentage of Caucasians, what percentage of Hispanics, what percentage of African Americans. So they took that town as a model, and then they started enrolling those thousands of people in Framingham, and then started gathering all the information. What's their age? What's their family history? Smoking history, diabetes, all these things, and then started longitudinally following and see how they are doing. And then if they have a heart attack or a stroke or chest pain, then everything was being recorded. So it was a path-breaking study actually. And again, in 1971, the offsprings of this cohort, the group that were enrolled, the kids were enrolled again in this data from ongoing physical examinations, and the disease conditions were recorded, and that provided a landmine of data to analyze and come up with things we know today. And those are we call as risk factors. The risk factors, what are they? Higher age, being of male sex, history of smoking, hypertension, diabetes, hereditary factors, having high cholesterol, type A personalities, being overweight, etc. Are the risk, were contributing to the plaque formation and the heart attacks. But as you see, some of these are modifiable and some of these are non-modifiable, right? If somebody is born male, you can't do much about it. If somebody is getting, older, you can't do much about it. These are not modifiable. But what we can modify is hypertension, diabetes, hereditary factors cannot be modified. Cholesterol, we can do something about it. Type A personality, again, this is a point of debate. You can't, I guess you cannot change a type A personality, but they can start doing stress reduction techniques. So the same thing that I spoke about in a pictorial format, smoking, high blood pressure. Lately, pollution is being included in that. Sleep deprivation causes stress, right? Poor diet and exercise causes, these risk factors. Being obese increases the risk. Diabetes, insulin resistance, high cholesterol, and being a smoker. And one thing, if you, one single point I want to put in the midst of the flow is hands-only CPR. When people collapse suddenly, it's somebody is a bystander. If they know 2 steps, they can save few lives. And they are call 911 right away and then start pushing hard on the chest. About 2 inches, push hard on that. That way, the heart is in a standstill. You're pushing the heart, keeping the blood circulated. Brain is continuing to get the blood supply. Organs are continuing to get blood supply until the help arrives. So hands-only CPR, please remember that. So from what I alluded to earlier, we need to look for the modifiable conditions. So how do we do that? You go to the regular physical checkup, right? Blood tests can be done. Blood tests can tell you if you have diabetes or high cholesterol. And then when physician evaluates you, blood pressure is checked so you can detect the hypertension. Then the physician can get a family history assessment. Somebody in the first degree relatives have high history of heart problems, then you will be under the radar. You'll be looked into and worked up further. So based on the risk factor assessment, we come up with a 10-year risk of atherosclerotic cardiovascular disease risk score. It's called atherosclerotic ASCVD risk score. And there are apps nowadays available. Most of the EMRs have automated calculating systems. Once the patient's data is entered, it gives you a 10-year risk, what's your 10-year risk of having a heart attack or a stroke? If any time it is more than 7.5%, that means we start treating the patients. And we classify them. It's more than 20% in 10 years. That means 2% a year. That's a high risk. More than 15%, it's a moderate risk. 7.5 to 15 is mild risk. So when you have a mild risk, we usually recommend lifestyle changes. For moderate risk, we start considering other things other than the routine blood tests. Again, these are the people that never had any heart disease or anything like that. So we sometimes can get a CT scan to look for coronary calcium scores. So it costs about $80 to $90. Most insurances don't cover it. It's a self-pay, but it's not very expensive. And you look for the plaque and the bulk of it. This works on the basis of a premise that calcium gets deposited on the plaque as time goes by, and CT scan can pick up calcium since it is radio opaque. So this is how it looks when you do a coronary calcium score. You're seeing this, if you can see my arrow on the screen. Can you see my arrow on the screen?
Yeah.
Yeah. So these are the arteries. So this is the aorta. This is a coronary artery. And then you see that it's a normal artery, looks like that, nice and pristine. And as you see, you can, there's like a white blob here. That's calcium. And you come to the severe calcification, all these arteries are loaded with calcium. And then there's a mechanism of calculating the coronary artery calcium score. If it is 1 to 100, its potential risk of cardiovascular risk is moderate. 0 is low risk. Anything more than 0 is moderate. And then anything more than 300 is very high risk. So the plaque burden is severe here. Plaque burden is moderate, mild, and minimal. So based on that, you can start treating them aggressively, like, treating with medications, putting them on an exercise program, things like that. So what tests can be done to look further? So as we said, other than this blood test and the coronary calcium score, we recommend stress testing to challenge the heart and see if the plaque is causing flow limitation, which can lead to chest pain. And then if that is the case, you start treating them with the medications. Sometimes, if you find an abnormality, you take them to the coronary angiogram in the cath lab, they might need stents or they might need bypass surgery. We typically do an electrocardiogram, or we call EKG, to look for rhythm disturbances, or do an echocardiogram, which is an ultrasound of the heart, to look for the valve function, thickness of the heart, squeeze function, etc. If at any time someone has symptoms, we do not consider risk score. If they don't have symptoms, we look for a risk score. If they have symptoms, then we automatically take them to the tests. When to call 911? This is very important, right? Because this is where, advanced countries have overcome some challenges in decreasing the mortality burden in a cardiovascular disease. So which 911 system is very well positioned in the country here. So if the plaque buildup gradually grows, as I said, we usually can deal with it in the physician office setting. But if they happen abruptly, the only way is you need to go into the hospital emergency room, and the best mode to go there is to get an ambulance. A lot of people, when they're having heart attacks, drive themselves to the emergency room. It's not good. In the process, if there is an arrhythmia happens, like ventricular fibrillation, a cardiac arrest, they don't even survive coming into the hospital. But if they're in the ambulance, they can be easily treated with a shock. So what are the symptoms? Typically chest pain, chest pressure, heaviness, shortness of breath, sweating, or palpitations. Sometimes the chest pain radiates to the neck and the arms. Sometimes more commonly in women, and especially diabetics, symptoms can be very atypical, like having just nausea, fatigue, or belching. They don't even know that they're having heart attack. Some people confuse heart attack with cardiac arrest. They're two different things. Cardiac arrest is an electrical abnormality of the heart when a person collapses suddenly when the heart goes into a standstill. Usually ventricular fibrillation, what we call. But heart attack can cause cardiac arrest. So they can coexist, right? So 911 is a very important thing to remember when somebody is collapsed. So men, men are from Mars, women are from Venus, right? So they do have differences, right? So what is the leading cause of death? A lot of people have confusion about it. I have come across people who think breast cancer is the #1 killer in women, which is not. How are women different than men in terms of having heart disease? What are the risk factors that are unique to women? What's the current status on the hormone replacement in postmenopausal women? Can heart attacks happen in women without blockages? Do women have to be having regular checkups like men? Or there is any particular group of women that should not get pregnant? So these are the typical questions that I come across. So I put together here. So the symptoms typically in men, again, it's not 100%, but majority of the men present with squeezing chest pain, going into the neck or the left hand, short of breath, sweaty, some nausea and vomiting. Apart from these, women tend also to have sometimes like just plain simple fainting, indigestion, extreme fatigue. So there are less warning signs can be manifested. So there's some emerging risk factors, especially other than traditional risk factors. There are some. For example, somebody has systemic lupus erythematosus. There's 3-fold higher risk of heart attack events. Rheumatoid arthritis, increases the risk. Somebody has gestational diabetes during pregnancy. Down the line, as they tend to get older, they're having a higher risk of heart attacks. For example, hypertension in pregnancy. Anybody who has hypertension in pregnancy, they have a 3-fold higher risk of having heart attack or heart disease down the line. Early menopause confers higher risk. So the longer the woman are in the reproductive age group, the more protection they get from heart disease. Like depression is more prevalent in women, which also doubles the risk of heart disease, ischemic heart disease, what we call. And also with the menopause, what happens is triglycerides tend to go up, LDL tends to go up, the good cholesterol, the HDL tends to go down. So women are less likely to achieve lipid goals. 80% of the women have more than 70, who are more than 75 have hypertension. That's a lot. So they're definitely different. So sometimes people do not have blockages. Like I spoke about the big arteries, right? So they come in with a heart attack, we do an angiogram, but all the arteries are open. Turns out that there's another entity, which is a microvascular heart attack. So if you see these little teeny vessels, the teeny vessels can also block and cause a heart attack, which you cannot do much about it, but we tend to treat with the similar kind of medications. So that's another possibility that can happen. Hormone replacement. It used to be, in good old days, any woman passes through menopause, they used to be put on hormone replacement. Some people have hot flashes. And then physicians used to think that, women need estrogen. So when they get menopausal, let's put them on estrogen. Turns out that a huge population study was done, which shows that people who are getting hormonal replacements are having higher heart attacks and strokes and dying. So now the recommendation is, American College of Cardiology does not recommend hormone replacement just because they're past the stage. American College of Gynecology does the same thing. North American Menopause Society, American College of Endocrinology, US Preventive Services Task Force. Everybody says don't do it. But there is a small subset of women, when they go through menopause, tend to have hot flashes because of the withdrawal from the hormones. For those people, hormone replacement is still indicated, and that risk, that kind of people do not have higher heart attacks. So in those people, it's perfectly okay to give hormone replacement. Heart disease and pregnancy. So there are certain valvular diseases, like for example, rheumatic heart disease in some, part in countries like India. Some women, complex congenital heart disease, people who are born with heart defects, they used to die before 15 in the past. Lots and lots of people are living into the 50s, 60s now because of early surgeries that are being done. So those people are getting pregnant. So those are the things that we face nowadays. Complex congenital heart disease, repaired, now they get pregnant. How do you deal with it? Pulmonary hypertension, there's a condition. There's a disease of aorta, especially there's a condition called Marfan syndrome. Family history of aortic dissection. And then some people, just when they get pregnant, they get a heart disease where the heart pump gets weak. We call it cardiomyopathy, peripartum cardiomyopathy. So these are the challenges that we can encounter sometimes. Other than that, predominantly in the women of reproductive age group, we don't usually see a lot, but there is a subset of people that we should be aware of. Okay, so that brings us to the topic for today. Desi heart, right? How are we different? So South Asians, like, when we say Desi, we all concur that if you take Pakistanis, if you take Bangladeshis, Sri Lankans, Indians, we pretty much share the same genetic traits. So in America, when we say Desi relates to South Asian. So it's like interchangeable. So South Asians represent 25% of the world's population right now, but they account for 60% of the world's heart disease patients. Can you imagine that? It's a huge number, disproportionate. The high incidence of this disease in this ethnic group presents a major public health crisis right now. And 25% of the heart attacks in young occur under the age of 40 and 50% under the age of 50. So we tend to have early disease earlier than, any given day compared to a Caucasian 10 years younger. So this is 10 years earlier than the general population on an average. So this is the New York Times article. Why do South Asians have such high rates of heart disease? So this is actually Alka Kanaya. She's a professor of medicine in UCSF. She participated in our trial, Desi heart disease and ZTV program. I invited her today, but she couldn't make it because of earlier plans. But I got some information from her, so I'm going to present to the audience here. So the masala study, like Deepak ji mentioned, because South Asians have higher risk of heart disease that we know from smaller studies compared to Chinese, Japanese, and Koreans. This is a population-based sample of about 1,160 patients, women and men aged 40 to 84 years, were enrolled in University of California at San Francisco and Northwestern University. The study was funded by National Heart, Lung, and Blood Institute, the same institute that funded Framingham Heart Study. So mediators of atherosclerosis, masala stands for that. So what the study shows us is South Asians, Desis, have excess risk for diabetes. That's the greatest risk factor disparity in South Asians. Twofold higher rates of diabetes when compared to their Caucasian counterparts. Higher prevalence of diabetes, about 23% compared to other ethnicities after adjusting for age and adiposity. 18% is the prevalence of diabetes in African Americans, 17 in Latinos, 13 in Chinese Americans, and 6% in Caucasians. So very high risk of diabetes in Indians. 9.7% of the participants reported gestational diabetes when they were pregnant. And women with gestational diabetes were 3.2 times more likely to develop type 2 diabetes eventually, compared to people who are not diabetics during their pregnancy. These observations highlight the need for early intervention in this young, high-risk population, which oftentimes is never done until it is too late. And the other thing is, in a masala study, people that are enrolled, they had a lower body mass index. Body mass index is a calculation that we do based on height and weight. And we come up with a score of anything about 25 is considered a high BMI, body mass index. And then waist circumference was significantly different compared to their peers in MESA study. MESA is a Hispanic, similar to masala, but done in Hispanics. Compared to them, South Asians had higher levels of visceral fat. For example, like, you can see, like, say, a slim and tall Deepak ji is there, right? You cannot just say that he doesn't have fat. South Asians tend to have visceral, like within the abdomen, the fat that is deposited in the intestines, the momentum that that holds to that. So the obesity doesn't have any meaning when it comes to South Asians, because whether they are overweight or not, they're having diabetes. Then diabetes means they're higher heart. So that's what this study throws light on. So pretty much you can put aside obesity as a risk factor in that. So diet, a lot of times, we have a theory, or we tend to think vegetarians means they're eating better. No, actually, if you look at the integration of the East and Western diets, once people come here, right? South Asian diet focuses on carbs like rice, lentils, chapatis, naan, and saturated fats like ghee and butter, with a conspicuous absence of focus on lean meats. When this is merged with the Western diet of dairy products, fried snacks, pizzas, and potatoes, it proves disastrous and has only added to the inherent predisposition to the insulin resistance many South Asians are now facing. Masala researchers also found that using the standard cutoff point to screen for diabetes, American Diabetic Association says anybody who has a BMI of more than 25 should be screened for diabetes. But based on the study here, they went ahead and decreased that risk of that score of 25 to 23 if you are Desis. So that's one important thing that has happened after this study. Almost 40% of the masala participants are vegetarian, common practice in India, which is widely regarded as heart healthy. But vegetarians who eat traditional South Asian foods, which are like fried snacks, sweetened beverages, high-fat dairy products, were found to have worse cardiovascular health than those who eat what the researchers called a prudent diet, with more fruits, vegetables, nuts, beans, and whole grains. So essentially, vegetarian itself is not healthy. What kind of vegetarian food you're eating is also important. People who eat a Western-style diet with red and processed meat, alcohol, and refined carbs, with fewer carb fruits and vegetables, were also found to have more metabolic risk factors. So what are the 7 steps if we have to do, to keep our hearts healthy? Eat a healthy diet, make vegetables and fruits, whole grains, and fish, mealtime staples. Limit sodium, saturated fat, and added sugar. Sugar is another culprit. Limit sugar. Get active. Log 150 minutes of moderate intensity activity, like brisk walking per week, or 75 minutes of vigorous intensity, like running. So 150 minutes in a week is about, if we take off the weekend, Monday to Friday, that means 30 minutes a day. Control your blood sugar. Aim for a fasting blood glucose of less than 100. It used to be 110 before. Now that has been cut down to 100. Watch your cholesterol, 4th thing. Strive for a total cholesterol of less than 200. Bad cholesterol of less than 100. Good cholesterol of more than 14 men and 15 females. Maintain a healthy weight. Target a body mass index of less than 25. In Desi, less than 23. Monitor your blood pressure periodically. Keep your numbers below 120 or 80. And then smoking. If you smoke, quit. So those are the 7 steps, if we have to summarize. So that's the talk time, So if you have any questions, I'll be happy to answer.
Yes, we will take questions. Sujeeth, that was very concise and extremely informative discussion. Many learning points for all of us. And in fact, by being Desis, we are part of the cohort, which is ongoing. We are the subjects without any intervention, most of us. And we also have a lot of habits that we can monitor and we can practice all sort of things for Monday to Friday. Something happens to Desi people when the Friday evening comes and we begin to socialize, and then that continues until Sunday, and everybody knows what I'm talking about. So we have a lot of work to do as healthcare providers and social organizations like ADS and others with our community. Because if you look at these numbers, we are all at risk, and not only we are passing it on to our offsprings, our children and grandchildren, and their risk factors are continuing. So there is a lot of burden that we all care and share. So I very much appreciate and thank you, and we will take questions. Historically, our audience takes a little bit of time before they will come up with their questions. So they are all brightest of the brightest people here who will ask questions. So I'll start with, as people are thinking to break the ice, some of the questions. What would you say, you said about the value of the exercise, how intense this exercise has to be in terms of 30 days or 30 minutes a day for 5 days? Could it be just simple walking, or they need to go to gym? Many of us have disabilities, back pain, knee pain, etc., cannot lift too much weight, and so on. What are your recommendations on that?
Yeah, so if somebody doesn't have a back pain or a joint pain, that means they can do treadmill, they can do elliptical, they can do simple, like just stroll down down the community. Probably doesn't give you much heart health, but brisk walking, 30 minutes of brisk walking could be equivalent to running on a treadmill of about 20 minutes. So that can be tried and achieved. And say somebody has back pain and knee pain, stationary bike is another possibility that they can think about. It's a pretty small investment. All you need is a little space, and most of us could afford a stationary bike, because most of us, a lot of homes have treadmills, right? Instead of treadmill, they can buy a stationary bike, because that pretty much takes off a lot of weight, and then you can still pull in, burn some calories and get your heart rate up. The bottom line is you're trying to increase the heart rate for a certain amount of time.
I have about 7 questions and comments. Anybody else is ready for the...
Dhiren Bhai has a question.
Dhiren Bhai, please go ahead.
I really enjoyed the presentation, very informative, and thank you. I want to ask you, what do you usually advise to people with diabetes, elderly, in form of primary prevention using baby aspirin, cholesterol medication, and medication like lisinopril?
Yeah. So, I tend to take off any guesswork usually. In my presentation, I spoke about atherosclerotic cardiovascular disease risk score, which takes, there are certain things that you take in coming up with the score. What is the age? What's your ethnicity? What's your total cholesterol? What's your bad cholesterol, which is the LDL? What's the good cholesterol, which is the HDL? Are you a diabetic or not? And are you a smoker or not? So based on this thing, we put in certain numbers into the score and we come up with a score, right? Anytime the score is more than 7.5%, you reached a point that, say, for example, they have a high cholesterol, you need to start treating. Say they don't, everything is borderline. Cholesterol is borderline, diabetes is borderline, but the skill score is 7.5 or more. You have a reason to consider a baby aspirin. So say, for example, somebody has diabetes that is equivalent to having a heart disease currently. That's the guideline now. So if somebody has diabetes, that's equivalent to having a heart disease. So that automatically buys you a baby aspirin. And then somebody is diabetic, there is a test called urine microalbuminuria, look for microalbumin excretion in the urine. And if it is above the cutoff, then you reach a point of using ACE inhibitor, which is a lisinopril, which decreases the protein spilling into the urine. So yeah, so these are the things that, the physical examination by the family physician or a primary physician is important once in a year. Once somebody has some risk factors, these are all the things can change every year. So once a year, check a urine, check a lipid profile, check your renal kidney function, hemoglobin, and all that. You have a risk profile assessed every year, and based on that, you could change it once in a year.
Gupta ji has the next question, please. Gupta ji, please unmute yourself.
I have information and a question. One is, I am 72-year-old, have gone through a couple open heart surgeries early age and a few years ago, all because of high cholesterol. And I have a genetically high cholesterol. And I just want to let people know that Rosuvastatin alone did not help me to lower my cholesterol. For a few years, I have been taking a shots called Rapatha. Rapatha shots I take twice or 2 shots a month. They are very, very helpful. So if someone in the group has a difficult time, you may want to speak to your doctor about it. Rapatha shots are helpful, and they really help you to bring the cholesterol to a manageable level. Second question I have is, I have a very high level of triglyceride, and 350. And I tried Basepa, 4 pills a day for almost 3 months, didn't do anything. Try to control my diet, some good, some not so good. But is there anything I can do to lower my triglycerides? Thank you.
Yeah, so until a few years ago, the statins, which are like, atorvastatin, simvastatin, lovastatin, all these statins were the mainstay of cholesterol therapy. But the downside is about 7 to 10% of the people who take statins have muscle aches. They don't tolerate it well. That was one of the problem. Second problem is there are certain people, like you just mentioned, the cholesterol is so high, the statins do not cut it, right? So for these people who have already had heart attack or a bypass or something, the new medications came in called Praluent and Repatha. They are monoclonal agents, basically, biological agents, basically. So they work as like an antibody, antigen kind of a thing. So because they are new, they are a little expensive. So there are certain restrictions on who will get it approved from the insurance. Somebody like you who have already had a heart surgery and whose cholesterol needs to be aggressively controlled, and the high intensity statins, what we call atorvastatin and rosuvastatin. If they don't control it, then we go to the Praluent or Repatha, and they really work well. And in your situation, what was your triglyceride before you went on Repatha?
I don't remember. You know,
It
it is about 300 range or so.
Usually Repatha actually brings down the triglycerides also. It should usually bring down that one also. So I'm presuming that it was much higher before, or in this mean process, in the time frame that you're talking about, few years ago your triglycerides were probably okay. In the last few years, there's much more insulin resistance in the body that has.
Because of the cost of video has stopped. I hope you can hear me.
Triglycerides are going up.
Yeah.
So that kind of insulin resistance, actually, they're go along together. So other than fatty acids, like fish oil, Vasepa is basically a branded fish oil. Fish oils are available over the counter. Omega-3 fatty acids, basically. Vasepa is omega-3 fatty acid. So there are branded names, there are over the counter. If that doesn't work and the triglycerides continue to be high, we tend to add another medication called fenofibrate.
Doctor, my question is, since the shots are very expensive, sometimes I try to take not every 2 weeks, I may take every 3 weeks. Is that a good idea or a bad idea?
It's not indicated that way. It was not studied that way, so we don't know. We cannot comment. But say if your levels are all controlled well, I have a few patients who say that it's very expensive, and I had luck with just giving once a month, and their expense is 50% decreased, and then their levels are all controlled well. I'm okay with it.
Okay.
But if you're taking every 3 weeks and the numbers are not controlled, then time to think back again and go back to twice a month. So,
thank you. Thank you.
So Sujeeth, I'm going to intervene with a question while others are still figuring out their question. And my questions will be progressively more aggressive and interesting. So please bear with me. My next question is about, as many of you know, that in addition to being an intensivist pulmonary doctor, I'm also a sleep specialist. And you know that the snoring and obstructive sleep apnea leads to sleep deprivation and causes major cardiovascular and neurocognitive complication, in addition to the public health hazards like motor vehicle accident and death. What are your comments about obstructive sleep apnea and cardiovascular disease in the context of Masala's study, or in the context of Desi genetic predisposition?
Yeah, that's an emerging risk factor, obstructive sleep apnea. And definitely we are getting a lot more literature on the topic. One thing is for sure, atrial fibrillation is one of the arrhythmic condition that predisposes people to have a stroke. That condition is definitely increased when somebody has obstructive sleep apnea. And the reason is, when people have snoring is happening because the airway is getting obstructed when they're sleeping. Oxygen levels go down, and that low oxygen levels contributed to heart distress. So if it's causing rhythm problems, I'm sure it can cause stress to the heart also. Any stress can increase the heart attack. So I'm definitely sure that it's definitely increasing the risk of heart disease. I'm not sure that aspect was looked into Masala, but I'm sure they are looking into in the down the line. They've been collecting data, but not everything has been published. So I think once they get good enough data, I think they'll come up and publish it.
Yeah, so clearly, as you said, this is emerging risk factor. We know that there is a lot of problem with snoring, and we ignore snoring because we believe historically that snoring is a benign process. It is not. I always talk about snoring and say that the God or nature has provided us with a trumpet. That there is something is wrong, and you have to listen to that trumpet and talk about it. Well, in a future conversation, we will probably bring that topic up. And ADS has the fortunate opportunity with a couple of sleep specialists available who can actually come and talk about that. So is anybody ready for the question? Well, I see that Mr. Jalotaji is ready to ask a question. And there is another question before Jalotaji. What is a silent heart attack? Somebody asked. Somebody asked, what is a silent heart attack?
Oh, yeah. Silent heart attack is, say somebody is a diabetic and then they're having fatigue and they're not able to explain the symptoms, but they're really having a heart attack. So people who sometimes, in diabetics, we do see that they might have had a heart attack in the past, and then we realize that later. Sometimes they might have had a huge heart attack and they didn't realize. And we realize only because they're not able to verbalize what's happening. We see in Stockton has significant amount of, Cambodians and Vietnamese. I see some people from those countries, where the social tradition is, doing this, burning the skin and things like that when they're having certain symptoms. So they're doing those things when they're having a active heart attack. Mm-hmm. So, that's what is called a silent heart attack. They're really having a heart attack, but they don't have manifesting symptoms. And that's a silent attack.
Jalotaji, please go ahead with your comments, and if you have any question.
Yes, sir. Coincidentally, my dad had actually passed away of heart attack, and there were no monitors available like yearly or 6 monthly tests available those days. He just passed away. I was curious about my health. In 2004, I was working in Bay Area where I had no symptoms, nothing, just out of curiosity wanted to check what is the condition of my heart, particularly plaque built up. There is a lifelike screening, private laboratory. It's a mobile lab. They come in your town. They do ultrasound ultrasonic test before plaque built up, I just pay $129 out of my own. My insurance would cover it. Just to be curious, they told me 2004, you have a mild plaque buildup. Mild, I gave it a number 15 to 30%, means average 25%, say mild, just arbitrary number. Then I went back to them 2006 and 2008. They told me it has in plaque buildup. They numerically gave me a window. They told me you have built up from mild to a moderate, which means about 30 to 50 or 40% plaque buildup. I said, okay, I go to my primary, they will not budge, they will not say, you have no symptom, we cannot talk to you. Insurance will not pay us and we will not recommend anything because you don't have any symptom. Unless your symptom, I said, what are the criteria of symptom? Oh, unless you have 80% build-up, you will not have any pain. That's what doctor just not said, 75% more point of worries. You start worrying about it. At time it was too late. I didn't want to wait till it's too late because my dad had passed away. So in 2008, mild. Okay, then 2012 became moderate, 50 to 70%. I went back to 16. They say it's 73%, numerically defined. I said, well, what we do? Go to primary. No symptom, cannot recommend you anything. Thank you very much. I come out. I, just like doctor said, you must jog or walk, vigorous exercise, 30 minutes minimum in the morning. If you can afford to go to a gym, do cardiovascular exercises, which I did, wonderful. But along with that, I also did some, like drinking 2 cups of water, 500, 600 mils of warm water in the morning to bring the density of the blood down, because overnight when you're asleep, your body does consume water, blood goes thinner by the morning, and then 50% of the deaths take place, heart attack in the early hours of the morning. That was very pinching to me, concerning to me. So every morning, get up, 2 cups of water. Then I started adding to that water anything which can dissolve the plaque buildup. Even it's not built up, mild is there, you take it like that on an empty stomach and no other food in your body system yet. I started taking apple cider vinegar, which is known to fat dissolver, hunger suppressor. Not too much. In 250 ml water cup of water, you add 15 mils of that, so that get diluted. I also started adding amla juice, which is full of vitamin C. I added aloe vera juice. 3 things I add every morning, take them in 2 cups of water. Then doing this thing religiously, morning exercise, vigorous exercise, drinking this on empty stomach, these juices, my plaque from 73% came down to 20-25% in 2018. In 2016, I was told it's 73%. So 18 came down to 16-20%.
Yeah.
Because I believe, as a chemist, I believe that as the plaque build up, layers are built up, other outer layers are thinner, not that dense yet. You can easily knock them off. And the lower layers of plaque, which are closer to the artery wall, they are denser, thicker, difficult to knock them off. Lighter, earlier you take action, better you are. Go spend your own money, get your heart checked up, plaque build up, checked up. Nothing precious than your own health there. And then take care of it. Be your own doctor. That I found myself. It helped me.
Right.
I do not have any problem like diabetes or prostate issues. Or lung issues. I don't have any of those. Only thing my worry was about the plaque buildup. That's my history. Thank you very much.
Yeah, so when they do a live screening, what they're doing is they're checking an ultrasound of the carotid, the artery that takes the blood into the brain, right? So some people tend to say that that's the window into the heart, that's we cannot look at the heart arteries by checking an ultrasound. But if you can take a look at the carotid artery, it tells you the state of arteries in the heart. So that's why we tend to do carotid ultrasounds. Now, the catch with the carotid ultrasound is when you see, as people tend to age, everybody will have plaque, right? Plaque formation starts in the teenagers, 17, 18 years, people start building plaques in the arteries. That's inevitable. Like, like I always say that, just take any lead pipe, there will be some blockages happening, right? So same thing with the arteries, there's going to be plaque. So that's not, the thing that we will detect when we do an ultrasound. You're looking at disproportionate amount of plaque. And when you look at the plaque, the way you estimate the stenosis, it's not the plaque burden, it's stenosis, is based on the velocity across the plaque. Based on that, we give a range, 15 to 49%, 50 to 69, 60, 70 to 80, more than 80 kind of a thing. So anything more than 49% is considered to be disproportionate plaque. So when you have a disproportionate plaque, I don't see a reason why your physician said you cannot be tested further. You should be tested further. If that plaque is more than 49%, your insurances will approve for further testing. You can get checked out for your cholesterol profile, diabetes screening. You can get checked out for a formal, complete ultrasound examination of the carotids. And if it is really confirmed with what life screening said, you will need further testing. That's one. Number two is when you already have a plaque, the regression of the plaque is something that has been a debatable topic. There are some studies that the high intensity statin like rosuvastatin has done in people who has shown a small percentage of plaque regression. So that means a 45% plaque can come down to about 40% plaque, right? So having said that, now some of the herbal things that we consume in Indian, diets and all, like you said, amla and things like that, it's very much possible that they might have some plaque regressive effects, but at least we don't know scientifically whether they really do it or not. So you might have a point, but I cannot comment on it because I don't have data to back it up.
Thank you. That was a very, very wisdomful response, I would say, because I come around this situation quite often. And in fact, I ended up discussing this matter with the medical board because a patient requests for prescribing something like this so that it can be covered by the insurance. So in a different context, not in the context of cardiac plaques. If anybody else has any question, please unmute yourself and ask your question. Put the question in the chat box or show the hand somehow so that we know that you have a question. In order to continue to save time, I'm going to ask the next question. Dr. Sujeeth, you mentioned something about the hands-only CPR. Dr. Dhiren Nanavati, I have a couple of other friends have been tossing around this idea for about 3 years that will educate our community for that middle of the night unfortunate event when a spouse begins to have the chest pain. The other spouse is the nearest person who can do something. And my question to you is for our audience's knowledge that what is the value of time and what is the value of that CPR and what will happen if they don't do it and what will happen if they do it and they do it right. Would you please make a few comments on that, please?
Sure. Time is muscle. There's a saying in cardiology. Just like stroke, same thing. Stroke or a heart attack, your cells in the brain or a heart are dying with every passing minute. So especially when we have a heart attack, when the patient hits the emergency room, we have a deadline, door to balloon time, what we call. Within 90 minutes, we opened up the blockage. So door to balloon time is there. So we are graded, our quality is graded based on that. The reason is time is muscle. So the sooner you get to the medical attention, the better it is, because if you linger on with symptoms for a few hours, the heart is already getting dead. Once it is dead, it's dead. You cannot revive it. So, but in the first few hours, it's not dead yet. It's just trying to die. If you reverse the blockage, you can treat it. So that's why the symptom onset, remember 911, and then say if somebody collapses and they're not responding, that means there is a possibility that the heart is in a standstill. So that's when you do hands-only CPR. So you call 911, somebody is on their way. That's number one priority, because you cannot get into the act of doing something to the patient and not call the real help. So the real help calling is number one, and then get to doing something. What can we do? Somebody collapses, they're not responding. That means start doing chest compressions. So a good chest compression, 2 inches, down when you compress the chest. You can compress up to 100 times in a minute. That's the recommended. So with that, what is happening is your blood is still circulating. The heart is getting blood supply, it's not dying. The brain is getting blood supply, it's not dying. So the acid doesn't build up in the body. That means when you go into the hospital, get the artery opened up, the body can still start reviving. That's the reason why we do that. Yeah.
So he made a very, very important point, and for the benefit of the audience and clarity, you will not do the CPR or these chest compressions when the person is responsive and they are talking to you. At that time, you will immediately call 911 and watch them. That's the first thing. So if you find somebody who is unresponsive, you check their pulse and there is no pulse or there is no sign of any activity, that's the time that you will start CPR. They may not be breathing or struggling, but they are totally unresponsive. That's the time to start the CPR. You will ask them for response. You call out their name, you shake them, see if they respond. Because if the person is responding, probably CPR is not needed at that time. They will tell you what's going on. So be very careful. Just don't start CPR because they are having chest pain or they are having shortness of breath. That time you call 911. And he already mentioned these are very aggressive compressions. The sternum, the breastbone, has to be compressed 2 inches or more and 100 times a minute. We will practice it one day through the ADS. That was our plan, was to teach people, but the COVID came, and of course, social distancing and all that. So there was no opportunity to practice. But you will not believe I can perhaps show the video sometime. My 3-year-old granddaughter and 4-year-old grandson, they were given training in CPR, that little kids. So the world is changing and we have to be prepared to deal with this kind of emergencies, because then you can save your family member for a meaningful life. Yeah. Because most of the time this is what happens, somebody is found down and things like that happen, and then we don't know how long they were down, and either they have a stroke, which is very dense and cannot reverse, or had a heart attack, as Dr. Punnam said, and cannot reverse. So thank you for listening. Dhiren Bhai, you have a question, please go ahead.
So this is a question for both of you. Because of COVID, we have not been able to plan what we have been talking about for 2-3 years. In the meantime, is there any kind of a short video or steps that either one of you can share with our members in the meantime, while we are still trying to arrange a live show or live CPR training? Is there anything that we can review and see while we are waiting?
Sure, we can send. We can email members with some video material. Definitely,
that'll be very helpful. Thank you.
Okay. Any other questions? Anybody is there to ask a question, make editorial comment? We are always very happy to hear of your experiences, etc. So far, I don't see any hand, no check box. Okay, let me ask. Okay, go ahead.
I just have a comment based on the entire presentation. It feels like the diabetes or the sugar is the one to control, and the other things fall in place.
Yes.
Right.
Absolutely.
So diabetes is given more importance to control.
Absolutely.
And that's a very good point. I don't think many people know that sugar is the main killer And then the clarification on the diet was very helpful, because most Indian people think that we are eating vegetarian food, so it's healthy, whereas we are putting loads of potatoes and fried and all that stuff in our diet, which is not healthy actually, even though it's vegetarian. So I really want to thank you for clearing two really main important points, and really like the presentation. Thank you.
You're very welcome. That was a very nice comment. I would like to add that we have the benefit of a nutrition specialist through ADS. She had presented before a few months ago, and in the heel of this talk, we would like to invite her back and address the issue specifically related to our dietary habits. So hopefully that will be a good exercise for all of us. Any other questions, please? Comments?
Since you mentioned the dietitian, her presentation is on ADS YouTube, and I can share the presentation link to anyone who requests it.
Thank you, Virtu. This is a collection of invaluable material that we are participating and contributing to YouTube. And of course, it is easily available to our audience, so that will be nice. I'd like to ask my last question, I guess. We can go on and go on. The alcohol has a very unique position in every society, and Indian society is no different. When I was referring to the observation and inhibition from Monday to Friday, and something happens to us, Desi people, there is mixed bag of information from cardiology. So on one hand, we hear about the red wines and tannins and amazing effect on the coronaries, and you go to the bottom of it, and somewhere in the background, the honest and patriotic Organization of America is funding it, but they are in turn not funded by the wineries. So there is some biased data. I read somewhere 2 hard drinks 3 days a week, which I think is quite a large amount of alcohol, will not do much good. From your point of view, straight on, what are your comments about alcohol in moderation or in excess?
Yeah, so alcohol in excess can contribute to cardiomyopathy, like, weakening heart problem. Apart from liver problem and things like that. But to a certain extent, alcohol is actually heart healthy. That's the good news, right? So what is excess? What is appropriate? So I'll try and make it simple. Women tend to metabolize alcohol lesser than men, right? So for one drink is considered like 30 cc's, 1 ounce. 1 ounce of 40% alcohol, which is whiskey, is 1 drink. And red wine, 1 drink is considered about 90 cc's. So, 2 alcohol drinks of 1 ounce each is the allowed for heart health, and 1 drink of whiskey for women. So it can be daily. So that's to make it easier. 1 drink in women, 2 drinks in men.
And that's a very, very important comment to understand, because one has to exercise a lot of discipline to stop yourself in exceeding the limits. Right. And I know when I asked this question and Dr. Punnam started answering, men were all smiling and ladies were looking at that, how can I argue with him anymore for drinking or not drinking? But that's a problem. Clearly, if you don't tolerate, you have predisposition, or you are drinking too much, always think about that alcohol is neurotoxic. And there is higher incidence of dementia, higher incidence of liver problems, higher incidence of, as Dr. Punnam said, cardiomyopathy, higher incidence of neuropathy. So variety of alcohol is one substance which impacts the entire body at every single level. So you really have to look at, everybody has different capacity. We are genetically designed and programmed to metabolize the alcohol either faster or slower. And depending on your metabolic preference, you will process the alcohol. And the longer it stays in your system, it may be doing some good, but also some bad. So you have to really make your judgment, informed judgment about drinking alcohol. And of course, it's socially accepted. So not much can be said about it. But those are some of the educational points around the alcohol. Dr. Punnam, thank you very, very kindly for answering that question. Let me see if there is any question in the box. No question in the box. Okay, I'm open right now before we have our concluding remarks and close the session at 7:21. Anybody else? Okay. Virtu,
Yeah.
okay.
If anyone has a question, please unmute yourself and ask now. This is your last chance. I think it was very good and self-explanatory presentation.
So on behalf of the ADS and our audience, I would like to profusely thank you, Dr. Sujeeth Punnam, for a wonderful presentation tonight. Quite educational and very, very interesting. Makes us think. And I'm sure that many of us will make some lifestyle changes based on this presentation and the pictorials, which really give a very, very powerful message in terms of understanding the material that you presented. And we would like to invite you back. We really appreciate your time tonight with us. Thank you so much. And everybody else, thank you so much for attending.
Thank you all. Thank you all for the attention.
Thank you, Dr. Punnam.
Thank you. Good night.
Good night. Good night. Okay.